economics are important. The patients sometimes are not thinking of the economics because they just want to get treated. But we live in an environment where we have limited resources, and the hospitals want to make sure they're not losing money. If you're losing money on specific procedures, if you're losing money on certain treatments, then eventually that treatment won't be able to be supported down the road. Economically speaking, if you help get rid of the clot earlier, you'll send the patient home earlier, number one. Number two, if you help get the patients to be on the floor and not go to the intensive care units, for example, by using the rapid PE protocol, where you can treat the patient on the table and send them back to the floor, that reduces utilization of ICU. That saves money, and that saves beds to the hospital and to the society. And number three, if you're able to get the patient to go home without utilizing oxygen, which happens when we treat these patients invasively, they will be able to get back in society faster. You'll save money on using oxygen at home. You'll discharge them home earlier. They probably will go back to work earlier. They will be less debilitated down the road. So all that has downstream economical benefits that it's not just limited to the cost to the hospital, but also cost to society in general, and for the patient in general to go back to full functioning early on, which has its own financial and other benefits. Using the BEC rapid protocol allows us multiple things. So number one, from a cost standpoint, I'm using one catheter as opposed to two. So that's going to save me money. And I did not mention that earlier because in general, we're thinking about what helps the patients the most. But if you're looking really at money as an administrator, you know that you're saving on one catheter compared, for example, to ECOS catheter, where you have to put two catheters in and send the patient for many hours in the ICU. So using one catheter because you're finishing treatment on one side and then you're continuing treatment on the other side. And frankly, even if you want to continue treatment down the road, what I have frequently done in the past before rapid PE, I would do one side treatment for the side that has less clots on the table, and then I go to the other side. And if I feel the clot burden is way too huge and I want to infuse more lytics down the road, I just leave one catheter. That saves the patients a stick because you have only one stick as opposed to two sticks. And that saves the patient a catheter and saves the hospital a catheter. Back to the rapid PE protocol, we're using one catheter as opposed to two catheters per patient. We're using less TPA. TPA is costly. People don't talk about that, but it could cost, if you're using, for example, 100 milligrams of TPA, that's at least $5,000. So you're saving a lot of dollars on using a smaller amount of TPA in a patient. Number two is cost of an ICU. Each ICU bed is worth several thousand a night from a hospital standpoint. And there are indirect costs. When you treat the patients, when you take the bed from another patient, you're making the hospital lose money on utilizing that bed for another patient. The longer you're utilizing a room in the cath lab, the more you're losing money because you're unable to treat another patient in that time. So you have a procedure that will take 30 minutes versus procedure that will take 2 hours. You could do 4 of one procedure versus one of the other. So then that's going to be money maker over there. So, or to put it better, that would be a cost-cutting way of doing things. So from an administrative standpoint, there's a lot of wins when it comes to the rapid PE protocol with the BEC catheter.